This program is a presentation of UCTV for educational and non-commercial use only.
Good evening. My name is Melanie Henry, and I'm an assistant professor here at UCSF in the Department of Pain Medicine and Anesthesia. And today I'm going to talk about some of the advances in non-operative pain management options. And we'll discuss, hopefully, some of the topics you've already covered, just sort of to reinforce those ideas, but also to introduce some new ones as well. So I'd like to start off with just very briefly talking about pain pathways, and in addition to define chronic pain and review what chronic pain really is and why it's important to want to treat this. We'll talk about the non-operative options for pain relief, in particular procedures and some of the medications. So reviewing this cartoon or diagram, what I'd like to point out here is a pain signal enters the body. Now, this could be anything: a dog bite, you stub your toe, you cut your finger, what have you. A signal comes in, and the peripheral nerves in that area of the body respond to this. It's a noxious stimulus, and it sends a signal into the spinal cord. It then crosses the spinal cord and then ascends up into the brain. Now, along the way, it's actually making contact with different aspects of the brain. And because of this, you'll notice that when you experience a noxious stimulus, several things happen at the same time. You might have a movement to bring your hand closer to your body. You might tear up. The area might turn red. And this is because of all these different areas the pain signal is responding in the body and along the spinal tract and along the brain. The reason why I wanted to introduce this picture and just briefly describe it is to tell you that we know that this is a track. This is creating a track in the spinal cord and into the brain. And if you have a signal, a painful signal that's being introduced into the body chronically on a daily basis, that we run into the possibility that you can actually have what we call imprinting, a painful imprinting track. And so this is very important to understand why we want to treat chronic pain the way we do. Now, this topic will be discussed later on in the lecture series in more detail. So when we think of chronic pain, you hear this term a lot, but do we really know what this means? What is chronic pain? And there's many different definitions for it. Now, I will tell you, most textbooks and most people define it as pain that persists greater than 6 months. But you can also look at it this way. It's a pain that persists beyond the course of acute disease to heal. For instance, you break your bone, you take an x-ray, you have a broken bone, you have a cast comes off in 2 weeks, the bone is completely healed, but you still have pain. That's chronic pain. And it's not within a 6-month period. Pain that persists beyond a reasonable amount of time for an injury to heal. A good example of this would be a burn or perhaps a shingles outbreak where you have a rash, vesicles, things that would cause burning in that area, things like chickenpox, what have you. But the rash goes away, the skin looks fine, but you still have pain, residual pain in that area. Pain that's associated with a chronic pathological process. That can, now keep in mind, many diseases can correlate within each one of these categories. But that example of this would be cancer or diabetes. It's a chronic pathological process that's occurring that could be affecting different parts of the body. It's a chronic pain. Pain that occurs at intervals of months or years intermittently. And that can be something like arthritis, migraine headaches, fibromyalgia, low back pain, rheumatoid arthritis. And so when you think of all of these definitions of chronic pain, I would have to say maybe 90% of us sitting in this room might even have chronic pain. We might be classified as that. So it's very important to understand why we want to treat chronic pain, because of we don't want to cause this imprinting. We want to prevent this, and we want to relieve the body of stress from this painful signal. So in this country, 80 to 90% of American adults have low back pain. This is what I see. About 80% of my population is low back pain in the pain center. Now, this is just one aspect of pain, but it is pretty predominant. Now, you might have reviewed this already, causes of back pain, but commonly you have disc pain. A normal disc looks like this. You have degenerative disc, which can be the natural aging process. You can have a bulging disc. And then you have sometimes what we call a herniated disc, and that's over here. The herniation pushes up against a nerve, and this causes radicular pain, or the sciatica that most people describe. We also have this very interesting little joint here called the facet joint. It's very tiny, but it's a real joint. It has fluid in it, just like a knee. It has little tissue in there as well. But this facet joint is responsible for when you extend your back and you twist. And this joint has this little tiny joint has a lot of responsibility, and it can become overworked and definitely develop arthritis. So this is a major cause of pain as well. But then we have spinal stenosis, which is also a natural aging process, pathologic as well, but it can narrow where the spinal cord runs within the canal. But there's, again, several different parts that can cause this back pain. So what are the treatment options for this chronic low back pain? Now, what I'm seeing nowadays with patients is they usually have already seen their primary care doctor. They're undergoing physical therapy, and they're usually taking Motrin or something like that, a very conservative medicines, conservative approach to try to help with the back pain. But then they come to me. They have an MRI in hand, and we can see that they clearly have a disc bulge. And they say, I'm not really getting better, and I don't really want to take any more medications. I don't want to have to be on 2 or 3 medications. And is there something else I can do? So this is really coming out of a need for patients who do not want to take medications. They really want a different option. So we'll talk about the epidural steroid injection and how successful that's been for treatment of pain, as well as discuss some other injections that can be performed on patients with back pain. So epidural steroid injections the indication is for any type of disc bulge or lumbar radiculopathy. So any type of sciatic pain, nerve pain into the leg, whether it's in the back of the leg, the side of the leg, front of the leg. And fortunately for us, there are 3 approaches to the epidural space. There's the caudal space, which is through the tailbone. There's the interlaminar approach, which is in the middle of the back. This is the most common approach for labor epidurals in pregnant women. This is the most common approach for people that are undergoing an epidural for surgery. And then there's the transforaminal approach, which is the side approach. And because we have so many options available to us, it really allows us to serve many different patients. We can perform these injections on patients that have back surgery, hardware, scar tissue, just because there's 3 different options, routes of delivery of medication. So in that sense, we're able to treat many different patients. So just looking at the anatomy of the back and understanding the epidural space, what you see here, these are spinous processes. This bone, it's been actually cut a little bit, but this is the bone when you feel your back, that's what you're feeling. It's a spinous process. In between those are ligaments, and here's a ligament here. This is epidural space, and then this is your spinal cord and your nerve roots come out here. Just a very simple drawing to describe that. Now, when we perform an epidural steroid injection in the pain clinic or for a disc bulge, we have previous imaging studies. We have an MRI. We know where we need to target. So we actually perform these injections under X-ray so we can identify and pinpoint the area that's concerning to us. When we perform this injection through the interlaminar approach, we use a technique called loss of resistance. It's a very interesting approach, and it's very interesting to see how it's performed, but also to think that this is how it's been done all these years, and we've never really had to improve it. It's pretty interesting. So what we do is we introduce this needle into the back between your spinous processes. This needle is lodged in a ligament called ligamentum flavum. This is so dense and so thick that if we put a syringe on the end of that, connected to the end of that needle, and we try to compress it with either air or liquid, we cannot. It's that strong of a ligament, it's that dense. So what we do is we slowly advance this needle, and right when we pop through the other end of that ligament, we get a give. We get what we call a loss of resistance. And to think this is what we've been doing all this time, it's really a blind approach when you think about it. Now, under X-ray, we can tell how deep we are. We can see, did we miss this, and are we, going further? And again, that's very rare. But you can see that this is how that approach is done. It's called loss of resistance. Now, the only way this technique will work is if this ligament is intact. So if you've had surgery, there's a good chance that that ligament's been disrupted and there's scar tissue there. We can't rely on scar tissue to give us that same feeling, so we can't use this approach on patients that have had surgery. So these are pictures of what you'd see in an X-ray in a pain center for a procedure. Now, this is the needle right here, and this is the L5 disc, or vertebral body. This is the disc space, and this is the 4. So we're between L4 and L5. The needle's placed here in the epidural space, and then once we get into the epidural space, after the loss of resistance, we inject contrast here. And this is about a 1/4 teaspoon of liquid. And this is how far the medication spreads. Now, we end up putting about 3 tablespoons in at the end with the medication. So you can imagine it's amplified quite a bit, and the spread is very great. Now, because this is interlaminar, and there's epidural spaces all around here, up here, it's a confluent space. So when you inject that medication, it will follow the path of least resistance. So if we try to inject and they have a disc bulge over here, the medication won't go over there because there's a good chance that's compressing the space and won't allow the liquid to get there, the medication. So we have to use other approaches for that to make it more specific. So with the interlaminar approach, you can see actually on this, even though we refer to it as a shotgun approach, meaning the medication will just scatter up and down many different ways, you could see for us we were really trying to target the left side. So we can still target one side or the other, but there's no guarantee the medication will get where you need it to go. So that's why you always check with contrast first to make sure we're treating the area we need. We can do this in the neck as well. This patient clearly has had surgery. That's not a piercing. This is actually a device in the neck. And so this is the epidural needle here. So they've had surgery up here, but not down here. So I can still use this space, and then the medication will go up and down. So you can see it travels quite a bit. So you can still perform these injections on people with hardware and surgery. So this is an example of the caudal injection. The needle is going through the tailbone, and it's not through bone, it's actually through a ligament. There's an empty, they call it a sacral hiatus that the needle's entered into. And it's not painful. I know the sound of it sounds painful, but it's not. The needle goes in, and then we thread a catheter up. You can't see it, but it's actually coming up here. Then we inject the medication. You can see the medication. It's even following a nerve root down. This is the S1 nerve root, and it's coming down here as well. These are foramens for S1, S2, S3. And so these are your nerve roots. And so we're able to deliver the medication right at the site, right where we need it to go. Now, this patient most likely had hardware, but also bone graft. And sometimes with bone graft, we can't get the needle where we need it, so then we'll go this approach. But otherwise, we would come in from the side, and I'll show you those pictures as well. So this is the side approach. This is what we call the transforaminal injection. And what you see here is the needle's coming in, and it's all along this nerve root. So we can really target one nerve root. So when we do this injection for therapeutic reasons. You're coating the nerve and calming that nerve down. It's a nerve stabilization. It's steroid. Steroid is a very potent anti-inflammatory. It's the strongest ibuprofen you can take. And so what you see is the medication diffuses into the nerve, stabilizes it, shrinks the swelling, or shrinks the disc around it, the inflammation, and then you no longer have the compression on the nerve. Hence, your sciatic pain is relieved. We also do these injections for diagnostic purposes. If people come in to see us and they have pain down the leg, but perhaps their MRI isn't consistent with what we would predict, we can actually do these injections to help diagnose the pain, to tell us, oh, is it this nerve root or this nerve root? Of course, if we're going to be doing diagnostic, we're just going to inject one nerve at a time because we want to see what the benefit is at each site. So it's a very handy tool, not only for therapy, but also diagnosis. We can also do this in the neck as well. And you can also perform an epidural or transfemoral anywhere along the spine, the neck, the thoracic, near where the rib cage is, or in the low back. So now you think, why would anyone go through this? Are they crazy or what? So what we're looking at are risks, and you have to look at the benefits. Now, in the low back, everyone says the same thing. I'm not going to have that done. I'm going to be paralyzed. So in the low back at L4, L5, the spinal cord is not there. The spinal cord ends at L2. At L2, after that, just nerve roots come down. So there's not a spinal cord there. You're not going to have paralysis. So what happens is there's always the risk that you can develop a reaction to the medication, anaphylaxis. We had no idea you were allergic to this. You've never had the medication and you have a response. Extremely rare. That would be with any medication, anything you take over the counter, any food you eat. It could happen to you at any time. So you just don't know until you try it. So the needle placement, you run in the risk of infection or bleeding, or what we call a dural puncture. So infection would only occur in a high-risk patient if they currently are sick or on antibiotics, and that's why those patients are not able to have the injection at that time. They cannot have any type of lesions or sores over the site of entry either. Bleeding occurs only if there is somebody's on a blood thinner and they didn't mention it. For instance, a high-dose aspirin, Plavix, something that's thinning their blood. Certain herbs can do that. And if this is not mentioned or people haven't stopped their medication in enough time, bleeding can occur. Dural puncture can occur occasionally, and you can get a headache with that, but we have a treatment for that, and that's also age-dependent. It's mostly seen in people under 30. Of all these things here, the infection, bleeding, dural puncture, in our clinic, we've been open about 20 years. We've never had an infection. And for bleeding, we've ruled out 2 people for epidural hematomas, and none of them existed. All the scans were negative. A dural puncture happens more frequently, but that would be when patients have previous surgery, or let's say it was difficult, or they were very obese and we had to use a longer needle, things like that might put you at higher risk for a dural puncture. But again, in my 6 years of practice, I've only seen 1. So it's very rare. It's very rare under x-ray. So nerve damage is a concern everyone has fears of, but you're awake during the procedure. When we perform that loss of resistance technique, and we pressurize that space and just inject a little bit of air or medicine. And when we go to inject that medication, it's pressurizing the epidural space. And so if there's something there that's blocking, it will feel the pressure. The pressure will be transduced across the space, and that can reproduce the pain. It does not mean we're causing harm. It does not mean we're damaging your nerve. It just means that it's pressurizing the space, and it goes to show you really do have a narrowing back there. But we discuss all this with our patients. We explain this. But it's a great option for people. And the reason for it is because it's very minimal side effects. If I had to give somebody a Medrol dose pack and place them on oral steroids, I would have to give them a very large dose to get to the site, and they would have side effects. There's many different side effects with steroids. This avoids oral medication. In most patients, this will take care of their pain, and they don't need to follow it through with any other medications. For those patients that are on medication, perhaps narcotics, and maybe they're taking 6 pills a day. This allows them, when the epidural medication starts to work, which is usually in 3 to 5 days, it helps them reduce the amount of narcotic that they're taking. So it actually helps in many different patients for different settings. And the pain relief is variable. Every individual is different in how they respond, but it can relieve pain for anywhere up to 3 to 6 months. So if you have a choice, you can either get maybe 3 or 4 injections a year, or you can take pills for 364 days. So it's your choice. So a lot of patients prefer to have the 4 injections instead of taking pills. So that's what we're seeing. That's a trend we're seeing. Now, interestingly enough, you have to keep in mind that back pain does not occur in isolation. It's not a single event that occurs. You have a back pain, you have a disc bulge, and next thing you know, you're walking funny, you're leaning to one side, and what happens is that's actually the body's way of saying, I don't like it when you turn to the right, so I'm going to go ahead and stiffen up all my muscles on the left, and I'm not going to let you turn because I don't want you to go there anymore. It's hurting me. So your body has a compensatory mechanism to deal with what's happening in your back. So what we see are trigger points that are developed, and what happens with these trigger points is the muscle is unable to relax. It's under so much stress and tension to keep you from moving and stabilizing that area that it develops what we call a trigger point. And it's not this obvious where it's a bump out of your back, but if you feel on your skin, you can feel a hard nodule. This is just a muscle fiber that's not relaxing. So this can put tension on the nerves that travel within the muscle, and that can cause nerve pain and also referred pain. You may have the pain up in the trapezius, but you might feel it way down on the shoulder blade. So it could be up in the neck, but you'll feel it in the shoulder blade. So what we do is we do what we call trigger point injections, and the theory behind it is threefold. So we have this needle, it goes into the site, and the needle alone, studies showed that a needle alone will relax the muscle, and that's actually where a lot of the premise behind acupuncture comes. So in one sense, we're using a needle to perform an acupuncture type release. Then we inject medication, and by spreading the muscle fibers apart, that relaxes them. And then we usually inject steroids. And a little bit of steroid in the muscle will also help inflammation. So you're actually treating that trigger point on three approaches with this. And again, this is something that can be treated at the same time as the epidural, but most people do not need to continue with these injections, but it can be. Now, if we do have trigger points in this area and they do not respond to steroids initially, we repeat this, but if they have, let's say, 1 or 2 days of complete pain relief and it wears off, then we consider injecting the muscle with Botox. And Botox will paralyze. Botox works by paralyzing the muscle, and we can use this in the back as well. I always joke with my patients, I'll have the best looking back in town. So, and they like that. So the piriformis syndrome is another pain syndrome that you should know about. And this is something that occurs when this piriformis muscle is attached inside the sacrum, and it attaches on the very side of your femur bone. And right down the other side of it, and sometimes through the middle of it, is the sciatic nerve. So if you have an instability in the hip or in this joint, the sacroiliac joint, a lot of times, again, what happens is the muscles around that joint stabilize things, and it becomes an accessory muscle. So it starts to work harder, because now my joint's not working, my hip's not working right, I'm walking funny. So then this muscle now is taking the brunt of the joint or the arthritis that's occurring. So what happens with this muscle? It thickens. So anytime a muscle's overworked, it's no different than going to the gym and doing bicep curls. You overwork the muscle. You're actually damaging the muscle and you're rebuilding it, and that's how your muscle forms. This muscle thickens to the point that it compresses this nerve. So you actually end up with the same sciatic pain as the person with disc bulge, but yours is for a different reason. So these have to be clearly identified before we start sticking needles in you to make sure we know where is the pain coming from. Now, this responds very well to physical therapy and, again, a trigger point injection. Now, we stick a needle in, it's right through the buttock muscle and goes all the way through down to the piriformis. This is deep. This is a deep muscle. And again, this muscle responds very nicely to Botox. Now, just to put things in perspective, So Botox paralyzes muscles. Most of us are probably familiar with it more so for the cosmetic reasons. And for a whole face, you use about 40 units of Botox. In this muscle, we'll use about 200 units. So you use a lot to really affect a big muscle. You need that much. And it's pretty significant. It'll last about 3 months. So a lot of people think of Botox as cosmetic reasons, but we use it mostly for muscle disorders. People that have cerebral palsy, people that have contracture disorders, people that have tremors, people that have the wry neck. They all respond very well to Botox, but we just forget about that because everyone gets caught up in the cosmetic aspect of it, which I'm not poo-pooing either. So the spinal cord stimulation is another aspect that we like to introduce to patients early on. And sometimes patients may have a disc bulge, they may have facet arthropathy or other problems, but they're not candidates for surgery. They're either too young, the disease process isn't bad enough to warrant surgery, but so the surgeon says, okay, we'll just hang out here until it gets bad enough to have surgery. Well, most people don't want to wait another 5-10 years in pain. So what are our options? What else can we do? So we have a spinal cord stimulator option. And this is, again, an epidural, but the epidural catheter has electrodes on the end of it. And this has been indicated for patients with basically radicular pain. It works the best, but it also works well for back pain and some other neurological disorders. So this is very interesting. The way it works is pain is carried, and I'm sure this will be discussed later on in the series. Pain is carried in many different signals, but the A delta and the C fibers are the pain transmitters. And interestingly enough, the A beta fiber is the non-pain. It blocks the painful stimulus. It blocks the delta and the C fibers. It blocks them. So if you can activate the A beta fibers, you'll block the pain signal from even getting to the brain. Well, this has been used for years, and we just never really thought about it. All those times when you would bump your knee or bump your head, and either your mom did or you're telling your kids, rub your knee, rub your knee, rub your head, you're actually activating the A beta fibers. All that time, we were actually doing something, and we had no idea. And so the A beta fiber is being activated by that rubbing sensation, and it's blocking the pain signal from getting to the brain. So that's the purpose of the spinal cord stimulator. So this is just another picture. What I really like about this device is you get to trial it. You get to use it for a whole week at home or wherever at work. You get to use it for a whole week before you decide if you even like it. So it's really rare someone will offer you a procedure like a surgery and say, well, we can, it's not like take it out for a test drive and come back. Once you have the surgery, you have the surgery. This is something you can actually use, and then if you don't like it, you just don't get it. So it's very interesting, and a lot of patients like it. The people that we've implanted are very, very happy with it. Now these are the actual leads. You can see there's 8 of them. We actually put 2 in. Sometimes you can put 3 or 4 in, and it stays right here in the back, and then we suture it down. It's a very simple procedure. It's not surgery per se. It's through the skin. It's actually percutaneous. So we have a lot of procedures to do. There's many things we can do, but sometimes patients are either not candidates. They could be on Plavix, they could be on blood thinners, they might have had a heart attack, they have stents in, they're not able to come off these medications, or they fear needles, this is just not where they want to go. So then we have medications as an option. Now when you think of medications, there's so many out there, and you think to yourself, well, how do people begin? Like, are they just picking them out of a book? I mean, when you go to the doctors, how do they know what to give you? So the World Health Organization developed a 3-step ladder to treat pain. So you have mild pain, moderate pain, and severe pain. So mild pain, you're using Tylenol and Advil. And for moderate pain, you're using short-acting narcotics. And for severe pain, we're looking at things like stronger medications such as long-acting narcotics. And we'll talk a little bit about each one of these. So Tylenol is a great medication. Now, recently it's made headline news because of overdosing on Tylenol. A lot of this has to do with the over-the-counter medications. So let's say you're on a medication that has Tylenol in it. It could be a pain reliever. But then you get a cold and a cough, and you go to the store and you buy your cough medicine and you call your cold medicine. I can guarantee you most of every one of those has Tylenol mixed in it. So you're taking a pill for pain, now you're taking cold medicine and cough medicine, and you've already overdosed on Tylenol. So that's really the scenario you're seeing more and more. It's just the over-the-counter compounding with the Tylenol. So you really have to be aware of what's happening. But Tylenol is such a still a strong analgesic that it's never been taken off the market except for when there was that arsenic scare. But other than that, it's never been really challenged. We think it's so useful still. Even the patients that have liver disease, we still allow them to have it. We just reduce the dose. So in this country, in the last 2 years or so, we just allowed it to be delivered through the IV. This has been used in Europe for years, and now we're using it here in the IV form. We still feel it's very important. Now, with the medication, as long as you keep it under 4 grams, you're safe, and that's 4,000 milligrams. So when you think of a narcotic, for instance, like Vicodin, that has 500 milligrams of Tylenol. If you take 2 tablets every 6 hours, you're fine. You're at 4,000 milligrams. But if you take 2 tablets every 4 hours, you've already overdosed. So that's another problem that was happening. A lot of people were giving ranges on how to take these medications, and now we're educating patients a little bit better about that. So now with the anti-inflammatory medications, there's many different medications on the market. There's ibuprofen. And ibuprofen comes as Motrin, it comes as Advil. There's so many different brands. There's diclofenac, that's another medication, that's prescription. Arthrotec is the other name, and these are they're mixed with other things. So Arthrotec is a medication that actually has another medication that helps protect the lining of the stomach. Voltaren gel is diclofenac in gel form, and the Flector patch is diclofenac in a patch form. It's actually a very useful medication, and I'll discuss that. Celebrex is one of the few COX-2 or anti-inflammatory medications that still remains on the market. It was in the similar class as Vioxx and Bextra. Vioxx was taken off the market for negative outcomes and risk of stroke and heart attack, but Bextra was taken off the market the company took that off themselves. Now, Mobic is another medication that is also available. So when you look at ibuprofen, it's actually a very good medication. It's an anti-inflammatory, so it reduces inflammation. Patients come to me and they say, "Oh yeah, I take it when the pain's really bad. I take it." I said, if you actually took it a couple days before, it would actually help. So when you use this medication, it's inhibiting an enzyme. It takes 3 or 4 days to actually inhibit the enzyme before the inflammation aspect decreases, before it actually can occur. So if you just take one pill every now and then, you're really not using it correctly. You need to take it for at least 3 days pretty consistently throughout the day. And as long as you're not exceeding 3,200 milligrams, you'll be safe. Now, some patients can't tolerate the side effects, so often, and the most common is at the stomach. So we usually recommend Tums or Pepcid, Tagamet, something like that, and that will help. There are a few people that are at high risk for adverse side effects. That would be a stroke or a heart attack, but you would have to discuss it with your cardiologist or cardiac surgeon before they'd be willing to let you take this medication. But the reason why I do like it is an anti-inflammatory. It can prevent damage in the joint in the long run. And you can actually use it before you know you're going to be active. If you know you're going to go skiing, start taking it 3 or 4 days before. If you know you're going to be really active and you're going to garden that Sunday, let's step ahead and take this medication. Think about it ahead of time, and you'll notice a difference. Now, the diclofenac patch came out about 2 years ago, and it was marketed for sports injuries, sprains, muscle tears, things like that. So the sports injuries and the sports industry has been using this for quite some time. It looks like just a simple white patch. It's about this big. I got these off the internet. I couldn't find any other pictures, and I didn't have time to ask my patients to pose with them on. So this is from the internet, and so this, as you can see, it wraps around someone's leg. They actually work really well. And the benefit with this medication is that the systemic absorption that the rest of the body sees, the stomach, the liver, the kidneys, is less than 3%. So if you actually took diclofenac pill and you measured the concentration in the muscle tissue compared to measuring it with this on, it doesn't compare. You achieve a higher rate of therapeutic value with this patch than you would do by taking it orally. So it's actually a very good patch to use. So now, what are other options? Now we start to get into, we have mild pain. Now we're going to get into stronger medications. And a lot of people fear narcotics. Now, narcotics are great medications if they're used correctly, if they're prescribed correctly. So narcotics come in two flavors, two types. There's short-acting and long-acting narcotics. Short-acting narcotics really need to be used for just intermittent or episodic pain. This is post-surgical, wisdom teeth removal, a hip joint, a knee joint, something very simple. You've had it done. You're going to be in recovery for about 2 weeks. This is what the pain reliever's for. You're not supposed to be on this for months and months and months. That wasn't the goal. That wasn't the intention of that medication. Then there's long-acting medications or sustained-release medications, and this is what we use for chronic pain patients. This is what we use for somebody that has chronic pain. And again, the reason for that is we really want to treat their pain so that we don't run into the long run of, just stressing the body with this chronic pain signal. So how does narcotic work? Is it anti-inflammatory? What is it doing to us? What's happening when we take this pill? So it's not an anti-inflammatory. All it does is block the pain signal. So when a pain signal comes into the body, it comes down this pathway. It gets to this terminal, and it transmits a signal via chemicals to the other site. And this is how it propagates. It continues like this. Here's one here, there's one here, on and on and on. And the signal just continues. So at the presynaptic and postsynaptic terminal, the narcotic works and it blocks the signal. So it blocks it coming and going. It completely takes away that pain signal. It's gone. But it's not really taking the pain away. It's not causing, it's taking the pain away, but in the signal away, but it's not taking away the cause of the pain. So the narcotics are there just to block the pain. So short-acting narcotics are prescribed typically every 4 to 6 hours, and the reason for that is that they really only last 4 to 6 hours. You take the pill, and it takes about 45 minutes to an hour for the plasma level to reach therapeutic levels, max dose, and then it starts to fade. The problem with that is it's sort of a roller coaster effect, up and down, and if you don't set your clock and wake up every 4 to 6 hours, you're going to be without pain relief, and most people aren't going to wake up in the middle of the night and take their pain medications. So that's one of the limiting factors with this medication. The second issue is it's usually mixed with Tylenol. Again, we find it very important because it does help with analgesia, but because it is mixed with Tylenol and the doses of Tylenol may vary, you can be limited on how many you take. So again, narcotics, there's a potpourri of them out there, and they're all by different companies, and they just have all these names. So Vicodin, Lortab, Norco are actually the same narcotic. It's just different makers, no different than Advil or Motrin. So you have hydrocodone is the narcotic, and it's mixed with Tylenol. Darvocet, anything with a set at the end of it is mixed with Tylenol. So Darvocet, Percocet, and this is the narcotic here. There are some narcotics that come without Tylenol, and we do use those frequently. So there is an option for that. You don't see it as prescribed as commonly because we like to use the Tylenol. Now, if you look at some of these mixtures, what you see is Vicodin is well known. It's been on the market for a long time, but it has 500 milligrams of Tylenol. Again, you're limited. You can only take 8 tablets a day. Now, if you're on Vicodin ES, that's 750. You can really only take maybe 4 to 5 pills, and that's it. That's all you can take. And this is you don't see this very often. It was big in the 70s and 80s when it came out, but it's not as frequently used. Lortab is another company that produces it, again, 500. So then Norco came along, and they actually reduced it to 325. So this pill is what we use now for patients that need more pain relief, and they need more narcotic. They come in different strengths, like the Vicodin and the Lortab, but you have less Tylenol, so you can use more pills. Darvocet's an older medication, and this is also a strong dose of Tylenol, 650. So those aren't used as much because of the limiting factor with the Tylenol. Now, long-acting narcotics avoid the Tylenol toxicity, and it also provides a more constant level of narcotic in the system, constant pain relief. So what you're seeing here is a picture, and we're going to come back to this. So remember what this looks like. This is your short-acting narcotic. It's up and down. It's that roller coaster. You take the pill, 45 minutes later, you're up here, and then it starts to wean off. And so this is a constant roller coaster. And then you have your constant steady state of your long-acting that's there constantly in the background treating your pain, blocking those receptors consistently. So, and that will be important later on when we talk about tolerance. Now, long-acting narcotics are long-acting for one of two reasons. It's either the chemical nature of the narcotic or it's the way we formulated it. So a long-acting narcotic that's chemical nature, the only example we have is methadone. That means that methadone, when it's dissolved and you digest it, it binds to the receptor, and the affinity that it stays with that receptor, the strength it's bound to that receptor is very strong, and it doesn't dissociate from it or detach from it very easily. These medications that are frequently seen, morphine, oxycodone, oxymorphine, fentanyl, are all in the delivery system. It's not how the body absorbs it. It's the way the pharmaceutical companies made it to deliver. So what we do is coat the pills with different layers. So it takes a while as it goes through the digestive system for it to release. So that's how that works. The fentanyl patch is a little different, and we'll talk about that. So there's really different ways. Now, I would have to say, honestly, I am a little biased. I would have to say methadone is my absolute favorite long-acting medication. It works very well. It has a very, very long half-life. It's 25 to 50 hours. They're small tablets, 5 milligrams, 10 milligrams. You can cut them in half very easily. You can cut them in quarters. You take it 2 to 3 times a day. It's very effective for neuropathic pain. It's the only narcotic that works on neuropathic pain. It works on NMDA receptor activity, and no other pain reliever does that, narcotic-wise. It's easy to titrate the dose, and it has little cognitive side effects. In fact, that I usually use it in most of my patients over 60. The one drawback with the drug is the social stigma. Everybody comes to me when I tell them, we're going to start methadone. They just say, I'm going to become a heroin addict. And I was like, where did that come from? So heroin, by the way, is a narcotic. You have to remember that. But the whole purpose behind methadone is methadone would bind to the receptors longer than heroin, and thus we were able, and it would decrease their craving for it. So that's how methadone came to be. And because it has such a long half-life, you can give it to them every 24 hours when they come to the methadone clinic. Now, of course, when we use it for chronic pain, you pick up the prescription at Walgreens or CVS, but there's no guarantee the pharmacist isn't going to look at you funny under the glasses. I can tell you all the stories from my patients. But it's a very safe medication. I will tell you that, again, social stigma, if anybody that's famous dies of an overdose, like a couple years ago or several years ago, Ann Nicole Smith had supposedly overdosed from methadone. You hear patients, I can't take that, but they don't think about, could she have been taking other things beside this? So they just focus on one thing. It's very amplified, and so people hear this. But it's a very good medication if you can get by the social stigma. A lot of family members get upset. My mom, you put my mom on this? How could you do that? And so we really try to educate people, and it's getting out there. You might actually, somebody in this room might be on methadone. It's a great medication. And it's the only IV form. It comes in IV form. So if you actually have to go to the hospital, it's the only medication they can give you IV that's long acting. Oxycodone, OxyContin, all those morphine, none of those come in IV form. So methadone's the only one that comes in liquid, IV, and pill. So morphine sulfate is another long-acting, and it's basically morphine. It comes in many different doses. It's easy to take. It's inexpensive. It's been around a long time. There are side effects associated with it. Swelling is very common. There are some metabolites that can build up if you have renal failure or kidney problems, and so this is not the medication for you. But it is a good medication, and again, it's not very expensive. Oxycodone is a medication, extended release. It's also called OxyContin. It's a very good medication. It has fewer side effects than morphine. And just keep in mind, every single time a new medication comes out, it's usually because it's more specific to to the site that we're trying to block, and therefore we have less side effects. In about 5 to 10% of the population, you end up with a stimulant effect, and that's where some of the addiction can come from, or the craving for it. And that's I don't know if you recall, many years ago, Rush Limbaugh was addicted to this, and you hear more and more people coming out addicted to this medication. It was abused by a lot of people because you can smash it and snort it. So the company in the last 6 months they realized there was such a high rate of diversion with this drug that they've actually reformulated it so that if you even the short acting, if you try to smash it up, it actually gets a gooey, like fat soluble like, and you can't inhale it. So it's amazing how the companies can do this. I have to give them credit. But it definitely has a high abuse potential, not so much now with the new formulation, but there's a high diversion for it. Again, the older medication, because people could sell it. So you were seeing a lot of people, and you can make a lot of money selling these medications. So Duragesic, or the fentanyl patch, is a great option for people. It's a patch that stays on your system. The medication absorbs into the fat layer, and then it's slowly released. Because of that, it's not always consistent in its delivery mechanism. You can take it, you can change it every 2 to 3 days. It just depends. Most people start off changing it every 3 days, but then we move to every 2 days if we need to. It does have very little side effects, the least amount of constipation, very little mental side effects. Clearly it's used for patients that can't swallow pills, they have throat cancers, things like that, or anatomical issues that they can't swallow. Or people that have memory problems. I have a lot of patients that are brought in from nursing homes or assisted living, and they forget. This is a great option. The person just needs to change the patch every 3 days for them, and you put it at a location they can't reach, so they can't take it off, so between the shoulder blades. So it's really a great option to treat patients. Now don't get me wrong, people can still abuse this medication, and I've heard, you can put a hairdryer on it, and it'll absorb faster. You can go into a hot shower, it'll absorb faster. You can put it in tea and drink it. So there's many different ways. I can tell you all kinds of stories about how you can abuse a medication, but it can happen, but it's very rare. Most people aren't that desperate for this medication, but it is very good. So fentanyl, it's also a clean medication. It goes through liver and kidney very easily, and there's really not any issues for failure in those patients. This is what the medication looks like. Fentanyl also was developed in a lollipop form as well as a sort of like an Alka-Seltzer, and that's the Fentora tablet. And this is this is for chronic pain of cancer. These are all approved for cancer. And so what you see here is it comes in different strengths, and it takes about 5 minutes to get into the system. It's absorbed through the cheek. And the nice thing about that is that it's the closest thing to an IV that I can give you at home. So for cancer patients, it's very important where if they move a funny way, or if they have pancreatic cancer, when they inhale, something like that, they have a sharp pain, and it takes seconds. It's a sharp pain that comes on and it goes away in 10 minutes. Well, if you take a pill for that, it takes 45 minutes to work, and it's really not going to help them. So this is a great option. Now, this medication initially was, to my understanding, was developed for actually pediatrics. So we could give this to a child to suck on while we started their IV and anesthesia before they went for surgery. It would relax them. But the problem is that it sort of outpriced itself from the market. It was too expensive for the pediatric element. So it was just approved for cancer. So Fentora is another medication that is fentanyl-based. It's new as well, and it actually comes on even faster. It's a mini Alka-Seltzer that goes under the tongue and dissolves, and that takes about 2 minutes, and it lasts a good 3 to 4 hours. So it's, again, a great option for cancer. I've only probably used it 5 times in my career just because the addiction potential is pretty high, and most patients can respond very well to the lollipops. So narcotics are great. If you use them wisely, this is what works well for patients if we need to use them. But then we have to deal with tolerance, and we think about what tolerance is all the time. And so tolerance is the ability to have to take more narcotic to achieve the same effect. It's a physiological process. It's not you. It doesn't mean you're addicted. It's just a natural event that occurs. It happens with almost every drug. You see it with caffeine. I don't know how many latte drinkers are out there. You start off with one, you feel great. Next thing you know, you're on 2, 3, or 4, and you're giving your paychecks to Starbucks. You're in a mess. This is what happens. And then 2 weeks later, you stop taking it, you get a bad headache, and then you start up again, and you can take one latte again. So it's the same principle. That's exactly what happens with narcotics. But what you have to keep in mind, we also know a little bit about, like, how can we prevent this? Because in chronic pain patients, how can we tell them, oh, just go home and just don't take it for a weekend and be in pain, really bad pain for 3 or 4 days, and then start up again? That's really hard to do. So we have to have alternatives and other ways around this. So what do we know about tolerance and why is it happening? What's happening there? So we can reproduce it in cell cultures. You can spray morphine on cell cultures and measure the metabolites. And over time, you have to spray more and more on to equal the same amount of metabolites. In animal studies, it's relatively reproducible. But in humans, it's really hard to study because we have the ability to have free mind and will to say, no, I'm not going to take that medication. No, I think I'm becoming perhaps addicted, or no, I'm not going to do this. So a lot of people are resistant to take these medications. It's very hard to study in humans. So what we do know is we looked at in humans the study of presence and absence of painful stimulus. We looked at narcotic dosing regimens, and we also looked at environmental psychosocial as well as age-dependent tolerance. So painful stimulus, we looked at 2 populations, people that take it for chronic pain and people that take it to get high, so IV drug users, or drug abusers. And what we found out is both patients develop tolerance. There's really no difference what your endpoint is. If you're taking the medication, you're going to develop tolerance. Animal studies have produced a little bit of conflicting data, but with humans on that front, it's actually the same. So narcotic dosing regimen is pretty interesting. I'll go to the graph. And what you have here, and this should remind you of that roller coaster diagram I showed you, intrathecal is spinal fluid. And again, remember, the narcotic is working on the nerve endings. So if you deliver the medication into the spinal fluid, you're getting it right at the source. You're blocking it right at the source, right at that transmission. So in the spinal fluid, we actually delivered some medication that blocks the receptor, or prevents the narcotic from working. So basically what you get is this peaks and valley, and we're inducing sort of a withdrawal on these rats. And so what we found out is that you get faster tolerance when you have this up and down and up and down. But if you have this long steady state, like the long-acting narcotics, we have slower tolerance. So if we know a patient has chronic pain, we're going to want to move forward with that long-acting narcotic so that we can prevent or at least slow the tolerance, so we have a longer period of time on one dose before we have to escalate. So it's very useful to know. The environmental psychosocial are always my favorite. I think those are always very interesting, the studies. And so what they did here was they took a rat, they put him in a cage, and they had them become tolerant to like 10 milligrams of morphine, and then they take them just take them out of their cage, put them right next to another cage, right next door, literally, and give them the same dose, and they die of respiratory depression. And so what they've determined is that just the stress of being in a new environment has either just compounded the factors to the point that they aren't able to tolerate that high dose. And so I find that very interesting. I thought that was a very interesting study. Now, in humans, the only thing you can really extrapolate, but there's so many confounding factors with it, are when you look at IV drug abusers that are found dead in their crack houses. It's usually in a home or a crack house that they don't usually frequently visit. So it's usually a neighboring one or someone else they don't know. So that's really the closest correlation we can make. But of course, there's so many other confounding factors with that. We also looked at the pill count, and we looked at patients, and we gave them the same dose, but it was given either as 3 pills a day or 15 a day. And the people that were taking a higher dose developed tolerance faster, and they thought their pain wasn't achieved as quicker as the people that were on 3. So all these things factor in, and it's very interesting how our mind can play tricks on us. So what really solidified things for me in prescribing narcotics is really the age-dependent information and the tolerance that we looked at. And when you think about it, neurons are you're born with the amount of neurons you have. 80-year-old neurons or 80-year-old people have 80-year-old neurons. So they're aging with you. They don't regenerate. They're not changing, but they're aging. So what we looked at was this very interesting study of rat information, and what they did was they used a tail flick as their indicator. So what that means is they take this rat, it's very humane, and they put a laser pointer like this, and they point it on their tail, and it's one that warms up. It doesn't burn. It cannot burn the skin, but it warms, and they can monitor when the tail will flick in response to that warming. And so before, I'm sorry this got cut off, but this is before narcotic. So before the narcotic, you can see the tail flick is pretty fast. It's like, I think this is milliseconds or seconds, it's like 100. But after you give the narcotic, you end up prolonging that time because it takes longer for them to feel it, and they can go longer before that sensation bothers them. But interestingly enough, at 3 weeks, in just 4 days, they become tolerant. So the same amount they have to give, and they're going to have to give more if they really want to block that. So then we looked at 3-month rats, and what we found out is we had to take it all the way to 11 days. And then we took it out to 6-month rat, and we had to go out to 14 days. And this was carried out actually for a year, 2 years, 3 years, and it showed the same process, that the older the rat was, the longer it took to develop tolerance. So with that preliminary data, a lot of us feel very comfortable giving narcotics to older patients. We're really not concerned about addiction, and it's really more of a generation belief. A lot of patients are afraid, they don't want to be on these medications, but it's actually very helpful, and we're really not worried about tolerance. So one of the other group of medications I want to talk about are neuropathic medications. Now, if you have a sciatic nerve pain, for instance, that is persistent, or maybe it's diabetic peripheral neuropathy, a nerve pain, it's a different pain. It's coming in on a different receptor. It's not a nociceptive pain. It's just a strong nerve pain, and what you're getting is tingling and burning. It's the classic, you hit your ulnar nerve, that's a paresthesia, that's a nerve pain. That's what you're feeling. When the dentist drills into your mouth, they hit the nerve, it's not anesthetized, you know you hit a nerve. It's very obvious, it's very sensitive in the mouth. And so you have different types of neuropathic pain. So we have diabetic peripheral neuropathy. You can post-herpetic neuralgia is after shingles. After the rash has dissipated and resolved, the skin is healed. You can have residual pain in that area that persists for quite some time. There's post-chemotherapy neuropathies. A lot of treatments for both chemotherapy for cancer as well as HIV and sometimes hepatitis can cause these neuropathies. And then, of course, there's just the basic sciatic nerve compression that can cause a neuropathic pain. Carpal tunnel causes neuropathic pain. So what we know about neuropathic pain is if you try to treat it with a narcotic, you're going to lose. You'll never win. You'll always have pain. You'll always have breakthrough pain. So narcotic is not the number one choice to start. I like this picture because it just really just makes you cringe when you think about it. And that is what neuropathic pain does to people. And so for diabetic peripheral neuropathy, of course, you want strict sugar control, and because the damage is coming from high sugar, destroying the nerve endings. You can use neuropathic medications, and we'll talk about those. And of course, if you have to, you can use narcotics. But that's really the last stage. We don't really like to use that. So this is a patient with shingles. This is not always a guarantee that they'll have post-herpetic neuralgia, but you can see this follows a dermatome. It follows a nerve, so that's why it's always linear. It always follows a path of a nerve. This will resolve, but the way we treat it here, we can do an epidural steroid injection. It's a nerve membrane stabilizer, and we can stabilize that nerve. It's inflamed by a virus, but we can still calm it down. You can use neuropathic medications and narcotics. Now we do not nearly see the number of cases we used to because of the vaccine. So I absolutely recommend the vaccine. People over the age of 60, but people younger are also receiving it if they're at high risk. So this is a great medication. you see it in the elderly because your titers are dropping. Titers are dropping because from chickenpox. So you're starting to lose that protective effect, and so then you're more susceptible. People that are on chemotherapy are more susceptible. People that are stressed are more susceptible. So what are these neuropathic medications that we can use, and how do they work? So these are a few that I listed. Now there's many more on the market. There's Cymbalta, and that's the name that probably most of you know. It's on commercials all the time. Neurontin or gabapentin's another medication. It's probably not advertised as much. Lyrica's newer, and that's on the market. Elavil is very old. It's an older medication. I call it the oldie but goodie, and we love that medication. It was actually initially it's a tricyclic antidepressant, and it was initially marketed for antihistamine, and they realized that it gives you the dry mouth, the dry eyes, and the dries up your nose, but it also makes you pretty happy, so they remarketed it as an antidepressant. So that's just the way things work. It's interesting. And then there's a lidoderm patch as well, and then we'll talk about that. So Cymbalta is a medication that works very well. When it first came out, it's what we call an SSNRI, and it's blocking certain receptors that cross that terminal. It's blocking those chemicals, so it doesn't allow some of them to pass. And so it's selective, and again, the more selective you can be, the less side effects you'll have. So compared to something like a tricyclic antidepressant or some of the older medications that are in this class, this will have less side effects. Now, the clinical indications. Now, when you look at it, you think, "My gosh, why would I take this?" It's really it's for depression. It's for general anxiety. It's also for OCD, and so that's what happens. My patients come in and say, "Oh, I read the label. I talked to my pharmacist. I can't take this. I don't have OCD. What are you trying to tell me?" So the hard part is that this medication was really marketed for diabetic peripheral neuropathy, but if you think about it, the more things that are approved for and we can show benefit for, you can prescribe the drug more, and it'll be authorized. So now, clearly, if somebody has depression, they're probably not going to be placed on Cymbalta if they really have a bad case based on the classification of their depression. If it's mild, they might use it, but it's rare. They usually use a stronger medication. General anxiety, it's used sometimes, but I mostly use it for neuropathic pain. What you have to remember with neuropathic medication is it's not site-specific. It's working on every nerve in your body, and that includes your brain. That means all your neurons in your brain. So for mentation, it does affect you sometimes. So that's the one downside with some of these medications. There's no weight gain. That's a big issue with people, especially with back pain when you think about it. The last thing I want to do is to prescribe a medication that's going to put 20 pounds of water weight on them. That's the last thing they need. They already have back pain. They might already be a little bit overweight. They don't need to gain any more weight. So the benefit is no weight gain, and I like that. The only side effect is nausea, really, and we recommend taking the medication at night for the first 2 weeks, and they usually sleep through it, and it resolves out after 2 weeks. It's contraindicated in people that have liver failure. Neurontin and Lyrica, this is gabapentin and pregabalin. This was one of the first ones that came out that was new compared to Elavil or the tricyclics, used for neuropathic pain. But to get to a therapeutic dose, it's 1,200 milligrams 3 times a day. The pills are huge. They're like horse pills. They bring them in. My patients, I can't take this. I can't take this. And I don't blame them, honestly. The liquid version is so bitter, most people can't take the liquid version either. So I haven't had too much luck with this because it's hard to get to that high a dose. And it's very slow. You start off at 300 milligrams 3 times a day, or once a day, then twice a day, 3 times, and you change it every 3 days. So it takes a long time to get therapeutic. But it's a good medication, and if you're in the hospital, we can go faster. It does cause sedation. It's really interesting about these medications. Everyone is so different. I'll have, like Neurontin, one person, "Oh, I took 300 milligrams. I slept for 3 days." And I have I'll have somebody that's like a litigating attorney. This, "Oh, it's fine. I could think on my feet. Everything was great." And it's just amazing how people respond. So you really have to try them to see if it works for you. But the number one side effect with all of these is really the sedation and the mental confusion. So Lyrica is, again, more specific, and it has less drowsiness and sedation. The problem is it's a little bit more expensive. You usually have to fail Neurontin before they can let you use Lyrica. So the lidoderm patch, I really like. This is another patch that you can use, but it's lidocaine. Lidocaine is the same medication that dentists uses in your mouth to numb your nerves, and it works very well. But it's a sodium channel blocker, so it works on muscle contraction as well. And we put this over the nerves or the area of the skin that we're interested in treating, and the medication is absorbed into that muscle and near the nerves, and it allows you to have some numbness and some pain relief. So it works really well on patients. You don't have to take a pill. You can just wear it. You wear it for 12 hours. You take it off for 12 hours, but it still works during the 12 hours it's off. You can either use it at night or day, depending on when you want to wear it. The disadvantage to all the patches is whether or not you have a reaction to the adhesive. That's really what it comes down to. But the patches, in my opinion, are a great way to deliver medication because it's pretty site-specific. It works in some people with diabetic peripheral neuropathy, not all of them, but sometimes they put it on their feet and it can help. But it's usually more for more discrete muscle disorders. It works well for trigger points. So if you can't have steroids, you don't want to stick a needle in your back, you can use this over a trigger point. So this has a lot of uses, so I do like to use those. So those are some of the neuropathic medications. And then lastly, I want to talk about some of the procedures, the other options that we use to enhance the procedures and medications. So I believe you've already had a lecture on physical therapy. So physical therapy, warm pull therapy, TENS unit are all ways to treat both myofascial pain and nerve pain. Biofeedback is an amazing, amazing skill to have. It's the ability to control a lot of the processes and becoming aware of the physiological response. So you can know in advance, okay, I know that I'm starting to tense up. I know this is going to happen if I don't calm down and if I don't slow my heart rate. This is going to trigger this. So it's very important. And if you get a very good biofeedback coach, you can learn a lot about your body, you become more body aware, and you can really stop a lot of these pains before they begin. Pain psychology has been shown in every study with chronic pain patients to be beneficial. The only real successful model for chronic pain patients is a multimodality treatment with pain psychology. What happens when people have chronic pain is over time, they don't even realize they're doing it, but their whole life changes. Their family usually sees it, but they're not even aware of it. They don't realize that, I realize if I walk to the store, it's going to cause my pain, so I'm just not going to do that anymore. And next thing you know, they're ordering in, or they're having a friend get their supplies for them. So I can't. Every single time I visit my grandchild, I notice that it flares up my pain. And next thing you know, they're not visiting their family as often. So there's these, but they don't realize it. They just go, I just don't feel like going today. I don't feel like going today. But actually, it's been sort of working in the back of their mind. It's more psychological, saying, I know if I really go, it's going to cause me more pain. So it's very important to have this pain psychology along with the medications, the injections, and all these other therapies that we can offer, or else we really won't have a successful model. The OSHA Center here works well with our yoga and acupuncture and other classes for people to talk about chronic pain. And so this is also another very important aspect. Alternative medicine approaches, I'm all for anything. People come back, I got this from wherever, India, China, whatever. Can I put it on my body? Yeah, give it a try. I can't say if it's going to work or not, but it's worth trying. A lot of the medications, we don't know what's in there. That's the only drawback. If it's going to have who knows what you can get. And a lot of people bring some things in, even from San Francisco, and I'm not quite sure where they're getting it, but you just have to go with it. So massage therapy is also, a lot of this is covered by insurance, believe it or not. It's actually covered. You can get this covered. But massage therapy is very important with the trigger points as well as myofascial disorders. But we realize at this point, we have a lot of options for us to treat patients, but we really need to do a little bit of everything to help to treat the individual as well as the pain syndrome. So I am at the Pain Center, so if you have any questions, feel free, and I can take questions now. Yes?
I wanted to ask about,
No, that's you, yes.
I wanted to ask about the interactions of things like Advil and ibuprofen, things like that, other drugs that seniors may be taking, like hypertension drugs or statins? Is there any problem?
So for those, you can have some problems with hypertension, but you'd have to ask your doctor depending on which one they put you on, but there's very little interaction with statins. Yes, ma'am?
You talked about limits of, I think, 4,000 milligrams per Tylenol. Are those, is that an average, or is that a firm limit for everybody, or does it depend on your age or weight?
No, that's a firm limit on with respect to age and weight, yes. For children, of course, it would be different. It would be based on weight. But once you are at 70 kilos or even a little bit smaller, which would be like 130 pounds, you're really in that dose range. Yes.
You talked about diabetic neuropathy and the treatments. These treatments apply to the idiopathic neuropathy as well?
It can, and yes, it would. Any of the neuropathies, regardless of the cause. Yes?
Do you know about the procedure where they inject a cement into a compressed fracture?
Yeah, that's a kyphoplasty. Yes. So let's see. I can take a quick picture of that and I'll show you that. So I actually have that, but on another presentation, but I won't show that today. I'll just show you on this. So what happens is in some patients, the vertebral body can collapse. So this is your vertebral body. It can collapse for different reasons. Usually it's most common a compression fracture. It can be due to arthritis. It could be due to osteoporosis. It could be due to cancer and metastases, that area. And what happens is that this disc or this bone will collapse and crumble, and it shrinks. And when that happens, it throws off the alignment. So when this gets smaller, this will get bigger. This will put stress on this joint, and then this foramen gets narrower. So what they can do is through the skin, you don't have to have surgery for it. Through the skin, we actually just put a giant needle, but it doesn't hurt, but a very large needle in here, and then we inject cement, and it solidifies that it solidifies that bone, and it keeps it stable. So yes.
What would be the side effects of that?
Well,
Stiffness afterwards?
no. What was your question about the side effects?
Well, the after effects of that procedure, I'm asking. Would there be more stiffness in your back?
Well, you wouldn't have stiffness, but you have to remember you've just taken a pretty flexible, even though it's bone and it's hard, it has some compressibility to it, and you've taken that out. So it's just like any mechanics. You've taken one thing, you've changed that site. So of course the bones above and below it will take the most brunt of impact, and most likely it'll be the facet joints. So it can affect that, yes. But if you're looking at it really is a valuable tool to treat compression fractures. Otherwise, you usually have to have a fusion and other type of surgeries for it. Yes?
Do the patches work when the pain's pretty deep in, like in piriformis area?
It wouldn't be for the piriformis. No, that's too deep. Unless you're really, really thin. So, but it's hard. It's rare. I have to tell you, in my practice, it's very rare. So it would be unusual. We'd use that for piriformis. Yes?
What's the incidence of type 2 diabetes with cortisone shots long term?
So there's no correlation with developing type 2 diabetes with injections. With taking oral steroids, I couldn't comment on that. For if somebody comes in with diabetes, we use there's 3 or 4 different types of steroids, and we know which one actually will cause more of a spike in their sugars than the others, and we use that. But there is no correlation to say that you'll develop type 2 diabetes with steroids if given properly. As long as you space your medication out every 3 to 4 months, it's safe for muscle, bone, as well as your rest of the systemic issues. Yes?
Your slide on the piriformis says it responds to PT, I assume.
Yes.
Physical therapy.
Yes, sorry. So the piriformis muscle is neglected a lot with stretches and exercises. So things like, I don't know if you've seen it, but clamshells where you're moving your leg in and out. Most people don't do those activities. That's not something you'd normally do. Even in your daily activities, you wouldn't be moving your leg in and out. So it really pinpoints using that muscle. And also what we'll do is find out what the weakening. Why is it being overstressed? Is it because your sacroiliac joint is loosening, and that's what physical therapy can help determine, or is your hip going? Is something happening in the hip? So those things all sort of correlate, and that's why. So we usually have to strengthen the muscles all around it to relieve that piriformis. Yes.
So you mentioned with the trigger point that the muscle's not relaxed.
Correct.
Can you explain what's going on physiologically? Is it that the motor signal is staying on?
Well,
What the Botox or the injection does to
so it's hard to say what happens with the muscle. It's usually a hypertrophy effect. So it's being overused. So it's in a constant steady state. Like the muscles that are constantly firing are like the ones in your spine on either side of your spinal cord. Because if those weren't always in contracting, you'd just be you wouldn't stand up straight. So there's certain muscles that are constantly their eye muscles are constantly being used. But over a time period, if you overuse them or look like one direction for a long period of time, you overuse that one muscle, you're going to have some problems. And that's what we see. So it's sort of a hypertrophy effect. So the muscle's just thickening and thickening and thickening, and then it just gets so tight it's just sort of in a state of contraction. So Botox works by blocking an uptake of acetylcholine, and it's just the mechanism of how the contraction occurs, but it blocks the site and it prevents it from absorbing. So for the small muscles around the eyes and mouth, you use a very little amount, but for larger muscles, you really need to put a larger amount in because it's a big muscle, and we inject it at 2 or 3 sites in the piriformis. The steroid is an anti-inflammatory. Again, it's steroid, and that would help decrease inflammation. So muscle can also become inflamed, so that will help with the inflammation.
Would methadone work also on neuropathic pain?
It can, yes, it does.
And in comparison to Vicodin, would you recommend one to the other?
For neuropathic pain?
I'm talking for chronic arthritic pain.
So if it's a chronic pain and I know the patient will be on Vicodin for a long period of time, I would definitely recommend a long-acting. And methadone tends to be one of my first choices, so yes.
And what would be the side effects of methadone?
The same as Vicodin. They're all the same. It's itching usually. Constipation's the #1 side effect with all narcotics. But those are the most common. Any narcotic can cause respiratory depression if taken too much at one time.
But the Tylenol concept is absent in the methadone.
Correct. So then you would supplement with Tylenol. Yes.
Is Alberset still on the market?
You know, I think they're in the process of actually taking it off. They're not making it any longer. So I'm in that process with a lot of my patients that was really the only medication that worked, and we're trying to find something that really to replace it. Yes.
I was curious about the cement therapy.
The kyphoplasty?
Yeah, the injection. How long does that last?
You know, that I can't really say. It's cement, yes, so it's permanent. I would say I really don't know the answer to that question, but I know it's not something you repeat. So it would be for hopefully a lifetime.
There's no risk of long-term deterioration?
Well, no, the deterioration doesn't come from the bone that has the cement in it. It would come from the bones around it because they're now absorbing more force. Yeah, there's a limit. There's all these rules, like there's limits to how many you can place, how many close together, because it really does change the mechanics a little bit of the back. But it is something that is very, very important to use in patients that have metastases, that have a bone tumor. It doesn't even have to be cancer. It could just be a benign bone tumor, but it's compromising the strength, integrity of the bone. So it's a great option for patients, and it's a very minimally invasive procedure.
You didn't mention anything about cannabis pain. Is there effectiveness from cannabis?
That's a very interesting topic. So it depends on who you ask, honestly. So we actually don't write for the prescriptions here at UCSF because we're federally funded and the federal government does not support that. We're happy to write you for the oral ingredient of the pill form, but it actually doesn't work the same. It's not really as effective. It's very good for certain things. It's great to put on weight. It's great to prevent nausea. It works in some pain syndromes, but it's usually our cancer patients, and it's usually more for their nausea than for pain. There's a few studies that have shown that it would be beneficial for muscle and things like that, but a lot of people use it for, headaches or muscle pain and those type of things. So there is some data to support it. We don't support it heavily. If a patient comes to me and says they use it, I don't say, oh, you have to stop it. I say, oh, okay, well, if it helps you, then it helps you. So it does have its uses. It's just the data is still mixed. There's really nothing that's glaringly that says this is absolutely you should treat everybody with this. So, yes.
How do you weigh the use of something like an epidural injection against your ability to diagnose the cause of pain? For example, the facet injection, you don't really know if it's the facet or if there's some other degenerative cause, or where the pain-generating body's actually coming from.
Well, that's a very interesting question. So what happens in most patients, they come, it's rare that you have an isolated incident and it's just, oh, you have a disc bulge. It's really rare. It's really more the classic, there was a weightlifter picking up weights and he was moving boxes, something like that. He or she, and they felt a snap and they're like, oh, and I had pain radiating down my leg. That's like the clear classic, this is what I have. But most patients don't come in with that. They have 3 or 4 different things that it could be. So there's 2 approaches. First of all, they come in with their symptoms. We do a physical exam and we look at the neurological exam, and we determine from that, and what the patient's saying is what could the pain be based on the physical findings. But then we have the MRI to go by. A lot of times they correlate, and then we'll see, oh, they have facets and you also have this leg pain. So then we tell the patient, look, you have several reasons to have back pain, but which one bothers you the most? And that's the one we'll start off with. And we just start, picking one site and we work on one. If that doesn't work, then we try another and we go to the other site. So we really classify based on the patient's need. If it's that each time they cough, or they internalize pressure, that's usually the disc. And so they're gonna want to do the epidural first with that. We can do any of these blocks without steroid first and just with local, and you can diagnose that way. And you can do several in a day if you need to do that. So there's many different ways to do diagnosis to determine which is the pain generator. So, and when it comes to the risk, facets are outside the spinal column. It's on the outside, so there's very little risk there. It's really what it comes down to. There's low risk on either of those procedures. It comes down to really the patient's preference at that point. Well, which pain do you really want to attack first? Which one bothers you the most? And that's how we decide. Yes?
Are there some long-term complications of the spinal cord stimulator?
Well, there's no long-term there's very few complications associated with them, but there are some drawbacks. For instance, you can still do everything you normally do. There's a few limiting. I don't think you can scuba dive. I think that might be one thing. There's some things that you can't do. Because it's fastened across the waist, if you do a lot of twisting, so if you're a big golfer and you golf all the time, it's probably not a great option for you because you'll have a high rate of lead migration, so the leads can come out. It won't hurt you. It won't harm you. We can replace these, but there's very little harm that can occur. But you can't get an MRI. That's the only drawback. But CT scans with contrast are really comparable to MRIs, so that would be the real major drawback. Yes?
Are most of the patients at the pain management clinic referred by a neurologist or primary care physician? Or in other words, have the diagnostics mostly been done?
A lot of times, but it is a referral clinic, so we like to have a primary care involved. A neurologist can also send to us as well, but sometimes a lot of times we order our own tests and we have to do our own diagnostic test as well. But a lot of times they come already with a diagnosis and, hey, can you help with the treatment? Yes. We feel that what's really important with respect to medication management is having one person in charge of this. And that also prevents overdosing. That also prevents medication interactions. So we elect to have the primary care doctor because they know what's happening with your heart. They're running the EKGs. They know what's going on with your liver and kidney. And a lot of times I don't. They're from an outside facility. I don't know what their labs are. So I give recommendations to the primary, and knowing their history, they really have to make that decision for themselves. Yes.
Let me ask about NSAIDs again. You
Yes.
didn't mention anything about aspirin, and I remember ketoprofen and Rimadyl are other NSAIDs that have been used. Any thoughts on that?
So ketoprofen we use in a cream a lot. There's compounding cream, so we use a lot of NSAIDs in cream form. I don't use the disease-modifying agents, but those are used in rheumatology, like Rimadyl and all those. I don't tend to use those. Those tend to come over from rheumatologists, but those are equally as good. They do work well. And ketoprofen we do use a lot. So. Any other questions? All right, well, thank you very much for attending.